A vast population of the world, especially the older generation, suffer from various types of chronic diseases. And it's important for them to know how to manage one's chronic disease in the most productive and positive way. It is my honor to introduce a pioneer and luminary in the field of chronic care and disease self-management, Dr. Kate Lorig. Dr. Lorig is Professor Emerita at the Stanford School of Medicine and a partner in Self-Management Resource Center, which offers self-management programs in 30 countries. She has spent the past 40 years developing, evaluating, and putting self-management programs into practice. Among others, she has worked with the United States Center for Disease Control and Prevention, the Pan American Health Organization, the National Health Service of England, and the Salvation Army in Hong Kong. Her present research interests include internet-based diabetes self-management, as well as small group interventions in diabetes and arthritis for English and Spanish speakers. She has published several books and journal articles in these fields. She is the recipient of multiple awards, including the Molly Mettler Award from the National Council on Aging Health Promotion Institute. She is the recipient of several other awards in health education. It is with immense pleasure I present to you Dr. Kate Lorig.
Good evening. I am so happy to be with you all from half a world away. As I speak with you, it is early morning near San Francisco in California, and I wish that there weren't many oceans between all of us. But I hope that to take you on a short journey about self-management, what it is, and how it can apply in hopefully our lives in the United States and your lives in India. Next, please. Let us start by defining exactly what is self-management. This is a definition that is used fairly broadly worldwide. It originally came from the United States Institute of Medicine. Self-management are the tasks that individuals must undertake to live with one or more chronic conditions. And these tasks include the confidence that they can deal with the medical management, that's taking their pills, doing their physio, their role management, doing the things in life that are important to them, working, being a grandmother, etc. And finally, the emotional management, managing things such as depression and fear that often come with chronic conditions. I will also note that the drawing here, Australian, it was done by Aboriginal people, of their interpretation of what self-management means. And underneath it says, people looking after themselves and each other. So now, shall we go on to the next slide? Why should we even care about self-management? Well, the reason that we should care is that people with chronic conditions live 99% of their time outside of the healthcare system. And it's during this time that they are self-managing. They can do that well, or they can do it not so well, but how they self-manage greatly affects their health and their quality of life. And what we're going to talk to you about today is how people can best self-manage well. Next, please. Before we start that, let's talk a little bit about chronic conditions in India. You may all have heard this many times before, but just to remember, about 70% of all Indians have a chronic condition. Women have more chronic comorbid conditions. That just means that they have more than one condition than do men. And the most common chronic conditions are cardiovascular disease, high blood pressure, depression, arthritis, and diabetes. And this comes from a recent longitudinal aging study by the Union Ministry of Health and Family Welfare. Next, please. I'd like to talk a little bit now about The purpose we've already talked about, that it's to improve people's lives and that of their caregivers, and also to reduce the use of the healthcare system. Next slide. Now let me talk a little bit about the Self-Management Resource Center. You see that on my name and in the logo. We're an organization that has developed programs, evaluated them, and finally put them into practice. These programs were all originally developed at Stanford University in the United States, and for the last 5 or 6 years have been managed by the Self-Management Resource Center. Today, we have the following basic programs. We have the Chronic Disease Self-Management Program for people with multiple mental and physical health conditions. We have a Diabetes Self-Management Program. We have a Chronic Pain Self-Management Program, a Positive Self-Management Program for people with HIV, and a Caregiver Program called Building Better Caregivers. So all of these programs have many things in common, but the content of each is different. Let us see the next slide, please. These are some of the things that all of these programs have in common. They're peer-led. There are 2 facilitators or leaders for each program, and these leaders come from the communities that they serve. They are generally not health professionals, although sometimes they are, but very rarely. We have standardized training for all our leaders, and this training is about, depending on whether you do it in person or online, it's between 24 and 30 hours. The workshops or the classes themselves are 2.5 hours a week for 6 weeks. They are built on self-efficacy theory. And all self-efficacy means if we know that if people are confident or sure that they can do something, they probably can. And if they're not confident, they probably can't. And so we do everything that we can to make people more confident they can actually do things. All of the programs have standardized format and content. So they are manualized and everything is written down in great detail. They are very interactive. It's not a teacher talking to students. It's a facilitator helping people to talk to each other and adding content. And these programs can be offered in small groups, and that's what you see here, or they can be offered virtually via Zoom or any other platform for that matter. Next, please. So I'm going to start out by talking a little bit about the Chronic Disease Self-Management Program. The objective of this program is to evaluate the effectiveness, and that by that we mean changes in behavior, health status, and health service utilization of a self-management program for chronic disease designed for use with a heterogeneous group of chronic disease patients. This means that people with diabetes and with heart disease and with arthritis and with depression all could be in the same workshop together. And of course, many of these people have 2 or more conditions. Next slide, please. This is a study that was recently completed. I should say that there are more than 40 studies now, the Chronic Disease Self-Management Program. The original 2 in English and Spanish were large randomized studies. And these findings, which are from a recent study that was done in Europe of 5 countries, really mirrors what was found in those original studies many years ago. The study was in Spain, the United Kingdom, Netherlands, France, and Italy. It had over 1,000 participants with a 6-month follow-up. 67% of the people in this study were women, and their mean age was 61. Next slide, please. At 6 months, there were statistically significant changes in self-rated health, which is one of the very best predictors of future health, in disability. They had better social and rural activities. That means they were doing the things they wanted to do. They had less depression. They were communicating better with their healthcare providers. They had better health literacy, which means that they understood more about what was happening to their health. And there were fewer reported medical errors. Next slide. Remember that I said that there were two objectives. One was to improve the quality of life of people, and that we saw that in the last slide. Here we see the reduction in healthcare costs. There were fewer physician appointments. There were fewer emergency room visits. There were fewer nights in, looks like we're missing the word hospital there, but there were fewer nights in hospital. And the average savings in this study were about 307 euros per participant. That means that they reduced their usage by about 620 euros. The workshop itself costs about 300 euros. And so the savings were 307 euros per participant. Next slide, please. Now I'd like to show you very similar information for the diabetes self-management program. Please don't worry, I'm not going to show you all 6 programs, just these 2. This program is very similar to the chronic disease self-management program. It is a 12-month study, not a 6-month study. The program is different in that the content of the program is very diabetes specific. This particular program is available in English, Spanish, and Chinese. And again, it is taught by peer leaders. This study was conducted by with patients from one of the large insurance companies in the United States, with approximately 1,200 people. Next, please. So how did the outcomes affect people? We talk very often about the triple aims. They had lower A1Cs for people with an A1C over 9, with at 1 year, their reduction in A1C was 1 full point. A1C is the single best, probably, way of measuring blood glucose control over time. And they also improved medication and lab testing adherence. So they were taking their medications more regularly and also getting their required tests. On a population basis, they had improved self-rated health, they had improved depression, and they had improved fatigue and sleep. And now let's look at the next slide to see about the cost savings. The per capita costs, the return on investment was approximately 2 for 1. And these data all come from the insurance company's claims data. The intervention in this case costs about $400, and the healthcare savings per person were approximately $800. So you can see that the savings per person are fairly similar in the 2 studies. Next, please. Many people ask, so why are these programs effective? And we know that some other health education programs, health promotion programs aren't effective. And what makes the difference? And I think that one of the things that makes the difference is that these programs are very carefully crafted. First, they're crafted among, and we'll talk about each of these: co-creation, self-tailoring, and the role of depression. So let's look at the next slide. By co-creation, we mean that the people that we want to serve are the ones that tell us what it is we want to study. We have focus groups. We talk to people one-on-one, and we listen to them very carefully. And you might wonder what this funny slide is, this funny class. This shows you one of the advantages of the program. This is a course that is being given in a warehouse, in a poor district, mainly Hispanic in San Diego, California. And you can see that this is a place that this is a workshop that can be given most anywhere. So we have participant interviews, we have focus groups, then we look at the literature and we look and see what has been successful, what is not. We have discussions with health professionals. And in those discussions, we ask, what are the things that are really important for people to do? Not what is important for them to know, but what is important for them to do. In most health education workshops, there are lots and lots and lots of messages. I went to 2 diabetes workshops, not our own, those given by good people in other places, and I counted that over 6 weeks, people were told to do or not do about 300 things. We try to keep our messages much, much shorter. In our workshops, in a 6-week period of time, we will probably give somewhere between 80 and 100 messages. And finally, we have ongoing feedback from our leaders and from our participants. And we are constantly making small changes when people tell us that we've gotten something wrong or that they don't understand. So this whole process of ongoing co-creation is very, very important. Next slide, please. All of the workshops have 3 core elements. Action planning. Action planning means that each week we help people to do what they want to do this week and to succeed. We don't care so much about what they do, but what we really do care about is they succeed. So an action plan may be, this week, I will walk after lunch 15 minutes. Or this week, I will write a letter to or an email to my aunt to find out how she's doing. They're very, very specific. So the second element is problem solving. And in this case, we actually teach people how to solve problems. So when somebody has a problem in the program, what we say to them is, what is your problem? Would you like some help? And then we have people make suggestions. So the second thing you do in problem solving is you get a whole group of suggestions. You look and see whether any of those might work. If you pick one, then you try it. And if that works, that's terrific. And if it doesn't work, then we might try another suggestion, or we might cast a broader net for solving this problem. And only after none of these things work do we decide that maybe this problem cannot be solved right now. Doesn't mean it can never be solved. It can just not be solved right now. The important thing is here is that many people go from, I have a problem, I know there's nothing that can be done, to helping them generate ideas and try different solutions. And we do lots and lots of problem solving around the participants' own problems during the workshop. And finally, decision making. People with chronic illnesses all have to make decisions, as do caregivers. And again, we teach a very formal decision-making process. What decision do you want to make? What are the advantages and disadvantages of each? And we show them how to make an informed decision. It's not that we make decisions for them, but help them make their own decisions. These 3 elements, as I say, are used over and over again. Next slide, please. Another very important piece of self-management is self-tailoring. And so to understand self-tailoring, we need to discuss a little bit about tailoring. In most health education, the person giving the program, the teacher, the leader, the health professional, learns something about the participants, and based on what they learn, they make suggestions. That's what tailoring is. For self-tailoring, what it means is that we give a structure and some information so that people can decide the changes they want to make and how they want to make them. Having watched this program all over the world, I can tell you that some of the problems, some of the concerns, some of the action plans are exactly the same in China as they are in Japan, as they would probably be in India, as they are in Spain. However, the way they are expressed and the solutions may be very different. And by letting people find the solutions within their own life contexts, we then get people to be moved towards better health behaviors. So this whole issue of self-tailoring is really, really important. Next slide, please. We need to talk about depression. One of the things that we have found is that about 30% of the people that come to our programs are clinically depressed, and that's using a standardized depression measure. This was also found in Spain. It's been found everywhere in the world that we've done this program. And one of the things that we found over time is that the self-management interventions, doesn't matter which of the 6 programs, actually moves clinical depression about the same amount over 6 months as do antidepressant drugs. Now, we're not suggesting that people not take antidepressants, because in some cases they're very, very useful. But we do say that cognitive behavioral therapy, as some people have found, we don't actually do cognitive behavioral therapy, but many of the elements of our programs are similar, really helps move this depression. And if you don't help people's depression, they're probably not going to change their behavior much. And so that's why I put this moving of depression as a core element in the program. Next, please. So in closing, let me just say that what we have found is that self-management is an effective and inexpensive public health intervention for assisting those with chronic illnesses. I'm sorry that I'm not going to have an opportunity to answer questions today, but please email me. I am about 30 seconds away, and I'll be more than happy to correspond with you and to answer questions and to help in any way I can. It's been my real pleasure to be with you today, and may you go in peace and health. Thank you.